Good afternoon, everyone, and welcome to the Massachusetts Medicaid Policy Institute webinar on MassHealth, the Basics. My name is Catherine Howitt, and I'm the director of the Massachusetts Medicaid Policy Institute. The Massachusetts Medicaid Policy Institute, also known as MMPI, is a program of the Blue Cross Blue Shield of Massachusetts Foundation. MMPI's mission is to promote the development of effective Medicaid policy solutions through research and policy analysis. We seek to broaden understanding of MassHealth and the important role it plays in providing coverage and in financing healthcare services for low-income residents. The goal of today's webinar is to provide participants with basic background information about MassHealth. Massachusetts is a leader in healthcare coverage and is taking innovative steps to continue improving care and reducing costs. MassHealth plays a key role in these statewide priorities. Also, healthcare coverage in general, and Medicaid specifically, continue to be a top political issue at the federal level. So understanding the foundations and the general trends of MassHealth is important in this context. Before we begin, I'd like to discuss a few housekeeping items. We are using the mute feature on the audio line during this webinar to reduce background noises. We encourage your participation and will be taking questions throughout the presentation via the Q&A feature. To submit a question, please click on the Q&A button located at the bottom panel of your screen. We have disabled the chat feature in this webinar to ensure that all questions are submitted via the Q&A button. We will try to answer as many questions as we can along the way, and we'll leave time to answer more questions at the end of the webinar. This webinar is being recorded. In the next few days, you will receive a link to the recording and a copy of the webinar slides. Both the slides and recording will also be made available on the Foundation's website. Finally, staff from the Foundation are available to present on the basics of MassHealth for individual organizations. Please reach out to me if you are interested in an in-person presentation of MassHealth, the Basics. My contact information is available on the last slide of this deck. With that, let's begin. Today, I'm joined by my colleague, Jesse Gottsagen, Senior Policy Analyst from the Blue Cross Blue Shield of Massachusetts Foundation, and Rachel Gershon, Senior Associate from Commonwealth Medicine, the Public Service Consulting and Operations Division of University of Massachusetts Medical School. Rachel and her colleagues at Commonwealth Medicine developed this chart pack with the support of MMPI. During this webinar, we will review many of the charts provided in the July 2019 update of MassHealth, the Basics. Our presentation today will be broken into 4 sections. First, we will start with a brief introduction to MassHealth. Second, we will dive into eligibility and enrollment in the program. Third, we will turn to MassHealth spending and cost drivers. And finally, we will check in on some of the big reforms that MassHealth is implementing. And we will stop for questions after each of these sections. So let's start with the very basics. MassHealth is the everyday name used for 2 programs combined. One is the Massachusetts Medicaid program, and the other is the Children's Health Insurance Program, or CHIP. MassHealth is publicly financed health insurance that serves low-income families and children, seniors, and people living with disabilities. Because of its focus on serving populations with various functional, behavioral health, and other needs, it covers typical healthcare services and many other services that commercial insurance and Medicare do not. So for example, MassHealth covers long-term services and supports in both nursing homes and community settings, which is not typically covered by commercial insurance or even by Medicare. Long-term services and supports include supports provided by personal care attendants, home health aides, and adult foster care providers. MassHealth also covers expansive behavioral health services, dental services, and transportation to medical appointments for most of its members. Okay, so why does MassHealth matter, and what is its impact on those it serves? Massachusetts leadership in expanding MassHealth coverage has presented researchers with an opportunity to measure the effects of MassHealth coverage. They found that MassHealth coverage leads, among other things, to better access to care and to improved health outcomes. Following an expansion in MassHealth eligibility in 1997, the state saw a dramatic drop in the uninsured rate for both adults and for children. And when MassHealth expansion was paired with other health insurance reforms in 2006, the health insurance coverage rate continued to improve as Massachusetts became the state with the highest rate of insurance. Researchers found that these reforms were associated with measurable improvements in physical and mental health and increased use of preventive care. These improvements were seen in both adults and in children. MassHealth coverage is also associated with financial protection and increased affordability for health insurance and care. I will now turn it over to Rachel from Commonwealth Medicine to lead us through the next section on who MassHealth serves and recent enrollment trends.
Thank you, Catherine. This table describes who is eligible for MassHealth. In general, MassHealth serves low-income families and children, seniors, and people living with disabilities. But whether or not an individual qualifies for the program is determined by a combination of their age and household income, and also whether or not they are pregnant or have a disability. MassHealth also has separate eligibility standards for people with particular health conditions, such as breast or cervical cancer or HIV. Income eligibility standards are based on the federal poverty level, which varies by family size. MassHealth is available to most Massachusetts residents with incomes at or below 133% of the federal poverty level. In 2019, that's below $17,000 per year for an individual, or just over $28,000 for a family of 3. Children up to age 18 are covered with family incomes up to 300% of the federal poverty level. One unique feature in Massachusetts Medicaid program is that the Common Health program for members with disabilities does not have income restrictions. People in Common Health with higher incomes pay premiums on a sliding scale. MassHealth eligibility for seniors is different, with different income requirements and some limits on assets. There are quite a few nuances to eligibility that are not covered in this slide. MassHealth staff and enrollment assisters are available to help sort out eligibility questions. Now that we've discussed who is eligible, let's look at how many people are actually enrolled in the program. This slide shows the trend over the last 12 years in MassHealth enrollment. As you can see, enrollment increased from 2007 to 2015, with the rate of increase rising around the time of Affordable Care Act implementation in 2014. But from 2015 to 2018, MassHealth enrollment has been relatively stable, hovering just above 1.8 million members. Starting with Massachusetts' early expansion of Medicaid through the implementation of the Affordable Care Act, MassHealth membership has grown. The Affordable Care Act allowed states to expand eligibility so that nearly all individuals under age 65 with incomes up to 133% of the federal poverty level were eligible for Medicaid, cementing state-based expansions into federal law. The high level of MassHealth participation contributes to Massachusetts' lowest in the nation uninsured rate. This slide shows the importance of MassHealth coverage to the health care of many different groups of people in the Commonwealth. MassHealth is critical to the health of families living in poverty, as well as to people with disabilities and people residing in nursing homes. At least half of the people in these categories depend on MassHealth for their health care coverage. You can also see here that about half of the people with disabilities and 4 out of every 10 children are served by MassHealth. The bottom bar of this chart shows that 1/4 of people on Medicare in Massachusetts also receive MassHealth. Medicare is the federal insurance program for seniors and people with disabilities. When a member is eligible for full MassHealth and Medicare, MassHealth pays for a lot of long-term services and supports and for the member's Medicare copayments and deductibles. Next, we'll take a closer look at the incomes of MassHealth members. This slide shows that individuals enrolled in MassHealth tend to have very low incomes. The majority of MassHealth members sit at or below 86% of the federal poverty level. In 2019 dollars, that is just under $11,000 for an individual per year, or just over $18,000 for a family of 3. As Medicaid expansion occurs nationwide, evidence is emerging that Medicaid coverage supports work. by giving low-income individuals healthcare security as they seek and obtain employment. More than 3/4 of non-elderly MassHealth members live in working families. These families work in a range of industries, particularly in sales, food service, cleaning, and maintenance. So how do these members receive their care? 70% of MassHealth members receive services through some form of managed care. As you'll see on the slide, there are a variety of different managed care options available to MassHealth members depending on their age and other factors. About 1/3 of MassHealth members are not in managed care. They include members with both MassHealth and Medicare, most of whom are not enrolled in a managed care plan. They also include people receiving premium assistance from MassHealth for other insurance, such as members who have student health insurance, employer-sponsored health insurance, or Medicare. Finally, members who have limited coverage, called MassHealth Limited, due to their immigration status, are also not in managed care. MassHealth Limited only covers emergency medical services. Before turning it back to Catherine to dive into how MassHealth is paid for and recent spending trends in the program, I will stop to answer questions that have come in from our slides so far. I see a question has come in asking, how will the public charge rule affect enrollment in MassHealth? Great question. To back up and give a little background, a rule commonly referred to as the public charge rule was issued in August of 2019 by the Department of Homeland Security. It would make it easier to reject requests for green cards, certain visas, and admission filed by low-income immigrants. One of the many factors the rule considers is application or receipt of Medicaid benefits after October 15th of this year. This rule would have gone into effect on October 15th. However, several federal courts have blocked the regulation and are prohibiting the administration from enforcing the rule. The administration is expected to challenge the court's ruling, and this case will need to work its way through the legal system before we will know whether this rule will ever be implemented. While the public charge rule is currently blocked by the courts, research suggests that it may reduce enrollment in MassHealth, even for individuals with the right to that coverage and even for individuals not directly targeted by the public charge rule. For example, an Urban Institute study from last year showed that some immigrants were avoiding public benefit use, even in families where everyone was a citizen and not subject to the rule. Commonwealth Medicine and the Blue Cross Blue Shield Foundation are currently working on a brief that will estimate the number of people who are likely to not enroll or disenroll from coverage as a result of this rule. Other groups, including Protecting Immigrant Families, have resources available to individual immigrants who have questions about the rule. Now I'll turn it back to Catherine to cover how MassHealth is paid for, as well as recent spending trends in the program.
And actually, before I jump into that section, I just wanted to address two other questions that I see have come in. So one person asked, can you tell the difference between ACO Model A and ACO Model B? So I just wanted to flag that that is a great question, and we are planning on covering that shortly in the section of this webinar that discusses recent reforms to the MassHealth program. Somebody else asked, are these slides going to be forwarded to everyone after the call? So yes, in the next few days, everyone registered for this webinar will receive an email with the slides and a recording of this webinar, and we will also be posting these on the Foundation's website. And with that, why don't I jump into the next section on how MassHealth is paid for and recent spending trends in the program. So first, let's look at the important role that revenues generated by MassHealth play in the broader state budget. When looking at the total Massachusetts budget, one key source of revenue for the state is federal revenue. Since the federal government reimburses the state for about 50% of the state's spending on MassHealth, the program generates a substantial portion of federal revenue for the state. In fact, MassHealth and Connector Care bring in 85% of all federal revenue budgeted for the state. Now let's take a deeper look into how the state and federal governments share MassHealth costs. The federal government reimburses the state for 50% of most Medicaid expenditures and about 77% of CHIP expenditures. Members made eligible under the Affordable Care Act's Medicaid expansion draw an even higher federal match. the federal government reimburses the Commonwealth for 93% of Medicaid expenditures for this population in 2019. Here's another way to look at state spending and MassHealth. This graph shows actual state spending in fiscal year 2019, net of federal revenue. So MassHealth made up about 36% of total state spending in fiscal year 2019. But because so much of that spending was reimbursed by the federal government, when you look at state-only spending, so net of federal revenue, MassHealth spending made up about 24%. So put another way, when you take into consideration federal revenue, MassHealth takes up a smaller piece of the state spending pie. So now let's take a look at recent spending trends in MassHealth. In this chart, the top line shows the actual dollar amount spent on MassHealth each year without adjusting for inflation. These are gross spending amounts, meaning that they include both state and federal dollars. Remember, the federal government reimburses Massachusetts for about half of its MassHealth spending. The lower line on this chart shows the growth in MassHealth spending adjusting for medical inflation. So what story does this chart tell us about spending in MassHealth? MassHealth program spending more than doubled in 10 years, but most of that growth is attributable to enrollment increases resulting from the ACA expansion. The pace of spending growth has moderated in recent years as enrollment leveled off post-ACA, with an increase in MassHealth spending of just 0.4% from 2016 to 2017. About half of MassHealth spending is in about half of MassHealth spending in state fiscal year 2017 was in the form of capitation payments, which are a fixed payment per member per month that the state makes to MCOs and other forms of managed care. For members in managed care arrangements, some services are still paid for under fee-for-service arrangements, including the majority of long-term services and supports. In the next two slides, we'll look at what's driving increases in spending on services. First, in MCO capitation, and then in fee-for-service and the primary care clinician plan, also known as the PCC plan. Among categories of per member per month spending on services provided under MassHealth MCO capitation, pharmacy spending grew the fastest. From state fiscal year 2013 to 2016, MassHealth MCO per member per month pharmacy spending rose 41%. During the same time period, pharmacy spending for fee-for-service and in the PCC plan rose 21%. Pharmacy spending was also rising nationwide, in part because of high-cost drugs such as the medication for hepatitis C. Massachusetts is implementing approaches to moderating spending growth, including holding ACOs accountable for some pharmacy spending. The state budget, passed over the summer, includes new state authority for MassHealth to negotiate with pharmaceutical companies. Looking now at spending for services paid for through fee-for-service or through the PCC plan, per member per month spending grew fastest for home and community-based long-term services and supports, or LTSS, during state fiscal years 2013 to 2016. Because MCOs do not cover most LTSS spending is in fee-for-service and the PCC plan. In other words, MassHealth members enrolled in MCOs still receive LTSS paid for via fee-for-service. During fiscal year 2016, Massachusetts ranked fourth highest among the states for tipping its balance of LTSS spending to the community rather than in nursing facilities. The state is exploring approaches to moderating LTSS spending growth, including managed LTSS. So where does all this MassHealth spending go? Well, in the course of covering healthcare for Massachusetts residents, MassHealth pays a significant portion of healthcare providers' revenues. This is especially the case for nursing facility and community health centers, which on average receive half of their total patient revenues from MassHealth. MassHealth also pays 43% of LTSS provider revenue, 34% of provider revenue for prenatal care, and 18% of total hospital revenue. As we will discuss next, MassHealth is using its role as payer to encourage delivery system reform throughout the state. I will stop here at the end of the section on MassHealth costs and spending to answer questions that have come in so far. Let's see. Oh, I see a question has come in asking, is MassHealth spending growing faster or slower than other healthcare spending? So this is a great question. It was something that was actually just addressed at the recent Health Policy Commission cost trend hearings. So according to data from the Center for Health Information and Analysis that was presented at those hearings, MassHealth was the slowest growing component of total healthcare expenditures in Massachusetts from 2017 through 2018. MassHealth spending grew 0.4% in that time period, whereas spending on commercial insurance grew 3.3% and Medicare spending grew 5.7%.
We have one other question. Someone was asking whether our enrollment and spending trends were referring to Massachusetts specifically or to the nation, and they refer to Massachusetts specifically. If you're interested in national numbers, there are some available, especially through the U.S. Census Bureau.
Okay, we will have time for more questions later, so I will turn it over now to my colleague Jesse Gottsagen from the Blue Cross Blue Shield of Massachusetts Foundation to talk about recent reforms to MassHealth.
Great, thank you, Catherine. So in 2016, Massachusetts received permission and funding from the federal government to enact large-scale changes to the way MassHealth providers deliver care and how that care is paid for, with the goal of improved quality and moderated spending. A signature piece of this reform was the introduction of accountable care organizations, or ACOs. ACOs, which were introduced to most members in March 2018, are provider organizations that MassHealth holds accountable for the overall quality and cost of their members' care. There are 3 different varieties of ACOs. Most of the contracted ACOs are the first type shown in this figure, an accountable care partnership plan. Partnership plans combine a provider entity and a health plan in a partnership responsible for providing and paying for comprehensive health services for its members. MassHealth pays partnership plans a capitation payment, which is a fixed payment per member per month, which the ACO is then responsible for allocating for care. There are currently 13 partnership plans, including, for example, Atrius Health partnered with Tufts Health Public Plans. The second type of ACO is the primary care ACO, which was originally referred to as Model B. This is an ACO that consists of a provider-led entity, not partnered with a health plan. Primary care ACOs are responsible for the quality and total cost of care for their members, similar to partnership plans. However, the payment scheme for this type of ACO is a little different. MassHealth pays providers in primary care ACOs directly. At the end of the year, MassHealth and the ACO will share the savings that result if actual spending for the year is lower than the expected costs of an ACO's members. They will share losses if spending exceeds expectations. The 3 entities currently acting as primary care ACOs in Massachusetts include Community Care Cooperative, or C3, which is an organization of 17 community health centers across the state. The other 2 primary care ACOs are Partners Healthcare ACO and Steward Health Choices. On average, these ACOs serve many more members per ACO than accountable care partnership plans. And lastly, the third type of ACO and MCO-administered ACOs are similar to primary care ACOs, except that the provider entity contracts with a managed care organization, such as BMC Health Nut or Tufts, for example. This managed care organization in turn contracts with MassHealth. The MCO will pay the ACO according to a negotiated financial agreement, subject to MassHealth approval. Savings and losses will be shared between the MCO and the ACO. Lahey Health is the sole MCO-administered ACO. MassHealth will test a few different payment models that aim to provide incentives for ACOs to meet quality and cost targets. In general, ACOs will risk losing money if their costs of caring for their members exceed a budgeted or expected amount, or if they deliver poor quality care. Conversely, ACOs may reap financial rewards if they can deliver care that costs less but results in good outcomes. So MassHealth ACOs are not only accountable for the total cost of care for physical health services, but also for behavioral health services. MassHealth also plans to phase in financial responsibility for long-term services and supports, or LTSS, later. To meet these needs, MassHealth ACOs and MCOs are required to work with community partners to support their members with complex behavioral health, or LTSS needs. Community partners, also known as CPs, are community-based organizations with behavioral health, or LTSS, care management expertise. They have extensive knowledge of the range of services available to best meet the needs of the populations they serve. There are currently 18 behavioral health CPs and 9 LTSS CPs. CPs work directly with enrolled members and their care teams to promote integration of care, improved member experience, and continuity and quality of care for members with complex needs. Specifically, CPs provide a range of supports, including performing outreach and engagement, participating in care teams, engaging in person-centered treatment planning, coordinating services, supporting care transitions, providing health and wellness coaching, and facilitating access to social services and community resources. Members may be eligible to participate in CPs if they are enrolled in an ACO, an MCO, or in the Department of Mental Health Adult Community Clinical Services Program. ACOs will also soon have an additional tool available to them to help improve health outcomes and reduce costs. This new ACO program feature, the Flexible Services Program, is expected to start in early 2020. Through Flex Services, MassHealth ACOs will be able to pay for certain health-related social supports in the areas of housing and nutrition that are known to affect health. Within the domains of housing and nutrition, there are certain services that may be provided through the Flexible Services Program. Examples of housing tenancy services include housing application assistance, first and last month's rent, and household setup costs. Examples of nutrition supports include home-delivered meals and application assistance for federal nutrition benefits. The goal of this program is to try and address certain social needs known to impact health and potentially reduce an ACO's total cost of care. In developing its Flex Services program, an ACO can choose which members are eligible to receive supports within the population of members that meets the general program eligibility criteria outlined at a high level on this slide. If you'd like to learn more about the MassHealth ACO program, including more about the CP program and Flex Services, please visit the Foundation's website to download our latest publication, which covers the ACO program and called What to Know About ACOs, the latest on MassHealth accountable care organizations. So to wrap up this section on reforms, I'd like to highlight another recent enhancement to the program in which Massachusetts expanded its suite of substance use disorder services covered by MassHealth. Expanded services, which are described on this slide, include residential rehabilitation, recovery coaches, and recovery support navigators. So I'll now break for Q&A before turning it back over to Catherine to wrap up our webinar with some concluding thoughts. As a reminder, please use the Q&A feature located at the bottom of your screen to submit your questions. So I see a question has come in here asking about the status of the Flex Services program at this time. That's a great question. What we know to date is MassHealth released its guidelines for the Flex Services program in August, and ACO used those guidelines to inform the development of their individual Flex Services plan. Each ACO's Flex Services plan outlines which populations the ACO intends to cover or target through its program, which specific Flex services the ACO will cover or provide, and which, if any, community-based organizations the ACO intends to partner with to provide Flex services. ACO plans were due to MassHealth in September, and MassHealth is in the process of reviewing proposals. The Flex Services program is expected to go live sometime in January 2020.
So we have some additional questions. Thank you, everyone, for your questions. Please keep them coming. One question asked to explain the numbers around ACO enrollment a little bit more. So going back to that slide, we saw that, for example, accountable care partnership plans, also known as Model A ACOs, there are 13 ACOs that are selected by the state, 530,000 members enrolled in those ACOs. That's compared to 345,000 in primary care ACOs. So Model A has more members total, but there are 13 ACOs sharing those members versus in primary care ACOs, only 3 ACOs. So when you look at how many members per ACO, Model A ACOs actually have fewer members, and Model B primary care ACOs have more. If you would like to drill down into these numbers more, I encourage you to refer to the Blue Cross Blue Shield of Massachusetts Foundation's brief on what to know about ACOs. There's also some new numbers out on the Center for Health Information and Analysis, CHIA's website, around enrollment, that you can do some interactive work around how many folks per ACO are enrolled. We also have a question about whether Massachusetts increased SUD treatment or substance use disorder treatment, whether that has changed spending patterns. I think the short answer to this is we don't know. We don't have the data for spending from that recently, from when those services were expanded. As you know, the state of Massachusetts is experiencing an opioid epidemic, including disease and death, that needs attention, and MassHealth has expanded SUD to address this. We have some of the most comprehensive SUD services in the nation. And MassHealth expansion of SUD services also coincide with increased federal funding for existing state SUD services. So in other words, the full cost of SUD services is not going to be borne solely by the state.
So I see that another question has come in about whether we can say anything about reforms the state is considering to programs that serve people enrolled in both MassHealth and Medicare. So I just want to back up and give a little bit more background on this. So more than 1 in 6 MassHealth members are dually enrolled, meaning that they're enrolled in both Medicaid and in Medicare. Being enrolled in both of these programs can bring benefits to enrollees, but it can also add complexity since these members have to navigate 2 provider networks and 2 sets of covered services. A few years ago, Massachusetts developed some of the earliest managed care programs for members who are enrolled in both Medicaid and Medicare. These programs are known as Senior Care Options, or SCO, and OneCare. As of January 2018, though, more than 3/4 of dually enrolled individuals are outside of these managed care arrangements. MassHealth is currently in the process of updating its OneCare and SCO programs with the goals of expanding enrollment and improving the care experience. These changes are collectively referred to as Duals 2.0, and they are expected to take effect in January 2021, pending negotiations with the federal government.
So we had some additional questions coming in. One of the questions is, how does recovery support compare to peer support? And so peer support is generally understood as someone with lived experience who comes alongside and helps someone work through their experience of medical care or behavioral health care. And the recovery support provided through MassHealth is very similar. I'm not sure if technically it would be considered a form of peer support, but it's definitely in that category of types of folks who can help people through their medical and behavioral health issues. I'm just going to read a little bit about what a recovery support navigator is. So, or a recovery coach. So there's 2 different kinds of recovery support through MassHealth. A recovery coach is a person with SUD lived experience that will serve as a recovery guide and role model. And a recovery support navigator develops and monitors a recovery plan in conjunction with the member. So there are 2 different kinds of recovery support now available through MassHealth. So the next question is, what is the difference between managed care and ACOs? That's a great question. So managed care can mean a lot of different things, both when you're looking legally, socially, like how care is delivered and organized and how managed care is paid. So when we're looking, for example, at accountable care partnership plans, the way they're paid is very similar to managed care through a capitation. The way they're organized is similar in that they develop networks of providers. What makes them a little different than traditional managed care that you might have seen maybe, 1990s era managed care is that it's connected with a provider. So the work of ACOs is to try to drive down delivery reform and payment reform more to the provider level, and also to make more robust quality measures and quality monitoring to try to get at this kind of magic, improving care, reducing costs without impacting the quality of care.
So I know a few more questions have come in, and my colleagues are going to be scanning them and developing answers to them. In the meantime, I'd just like to provide some concluding thoughts to today's webinar, and then we will return to answering questions at the end of this slide. So please keep your questions coming. So let's review a couple of the key takeaways from today's webinar. We started by diving into eligibility and enrollment in the program, and we found that MassHealth is an essential safety net for low-income people, children, seniors, and people with disabilities. MassHealth covers more than a quarter of the Massachusetts population and is a major reason why Massachusetts has the highest level of health insurance coverage of any state in the nation. While enrollment in MassHealth spiked after implementation of the Medicaid expansion in the Affordable Care Act, enrollment has been relatively stable for the past 4 years. Next, we turned to costs and spending in the program. MassHealth is jointly financed with both the state and the federal government, both contributing to its costs. For every dollar MassHealth spends, the federal government typically pays the state around 50 cents. For some expenditures, the federal government pays even more. We also found that, due in part to moderations in enrollment, MassHealth spending growth has moderated in recent years, post-ACA. Spending on prescription drugs and home and community-based long-term services and supports grew faster than the rest of the program. Finally, we covered recent reforms implemented in MassHealth. MassHealth, like other health insurers, has operated in a fragmented delivery system, making it difficult to coordinate care well, particularly when there is a need for connections across physical health, behavioral health, and long-term services and supports. To address this need, MassHealth is in its second year of a new delivery system reform effort. As a result, half of MassHealth members are in accountable care organizations, or ACOs. MassHealth is also adding services to address a growing need for substance use disorder treatment. So I will now break for our last opportunity for questions in this webinar. As a reminder, please use the Q&A feature located at the bottom of your screen to submit questions. So I see that another question has come in asking, has MassHealth premium assistance changed for Medicare enrollees? So this is a good question. And again, I want to start with a little background. There is a MassHealth program that helps pay for premiums and cost sharing for low-income seniors and people with disabilities who are enrolled in Medicare. This MassHealth program is called the MassHealth Buy-In. It's also known as the Medicare Savings Program, or MSP. The Massachusetts budget, which was passed over the summer, expanded eligibility for the MassHealth Buy-In. So starting this upcoming January 2020, income eligibility will be expanded from the MassHealth Buy-In program from 135% of the federal poverty level to 165% of the federal poverty level. And also the asset limit for eligibility in this program will be doubled. And this expansion is expected to significantly reduce Medicare costs for about 40,000 individuals. It's also going to make more individuals eligible for help with their pharmacy costs.
Great. So there is a bunch of new questions. Thank you so much. One of the questions is whether substance use disorder treatment options will be delivered by MCOs and ACOs only, or will they also be paid via fee-for-service? And the answer to that is that these new SUD services are available regardless of delivery type, meaning that they are provided whether a member is an MCO or an ACO or in fee-for-service. If you want more information about this, I would recommend looking at the approval documents around the 1115 waiver, and we are happy to direct you to that if you would like to email us. There's another question about whether you know the per member per month payments for ACO partnership plans and whether they vary. We don't have those payments available at the tip of our fingers right now, but we do know that they vary by a number of factors, including historical spend and also the goals of the state of Massachusetts. We'd be happy to answer more detailed questions about that offline. There is a question about how any ACOs have expressed interest or are planning or paying first and last month's rent as part of flex services. So we don't know the information around each individual ACO's flex services plan. We can refer to what's called the flex services protocol. It's a document that is part of the approval from CMS. It's available online and we can direct you to it. And that protocol states that CMS has approved first month's rent and security deposit. But again, flex services is not an entitlement, which means that folks who are eligible don't automatically get flex services. It's determined in some part by decisions made by ACOs through their flex services plan.
So I see we have another question asking, what is LTSS? LTSS is the acronym that we use to describe long-term services and supports. This includes supports provided by personal care attendants, home health aides, and adult foster care providers. You'll hear us use the term community-based long-term services and supports, though some long-term services and supports are provided in nursing institutions.
So we also have a question also around substance use disorder services, how they are reimbursed, for example, the residential services we discussed. So SUD services are available, as we talked about, regardless of delivery system, whether you're in fee-for-service or in a managed care arrangement. And then how they're paid for depends on which delivery system you're in. I know that ACOs include behavioral health as part of what's called the total cost of care, meaning that the cost of SUD services, some, if not all, are considered when either setting capitation rates for accountable care partnership plans, or when you're looking at the Model B, the primary care ACOs, figuring out what the shared savings, shared loss at the end of the year looks like. Here's another one. Will there be recovery housing coverage with the SUD reform? I'm not sure for the specific recovery housing. I can speak to housing in general. So usually Medicaid does not pay for housing supports directly. As we mentioned, in flex services, there is some opportunity to pay first month's rent and security deposit. And there are other opportunities, for example, through the community support program and also recovery navigators to help find and keep housing. So some help with the housing search. Obviously, with Massachusetts affordable housing situation that we're in right now, housing can be difficult for folks on MassHealth, and I think that the state is exploring other options. In the past, they have looked at other types of funding that is not through Medicaid, so does not have to ask the federal government for approval through the federal Medicaid program.
So we have another question. Will Model B ACOs also participate in the flex services, or is this strictly for Model A? So yes, to clarify, all models of ACOs are eligible to participate in the flex services program.
We have another question. Is coverage for MassHealth now only through ACOs and MCOs? Is individual fee-for-service no longer available? So the answer to that is there are still a variety of delivery systems for MassHealth members. Some members are asked to choose a managed care provider, meaning an ACO, an MCO, or the PCC plan. And if they don't choose, they're assigned to one, and there are different rules around enrollment and switching. There's also a variety of managed care type arrangements for folks who have both MassHealth and Medicare, including OneCare, the Senior Care Options Program, and for folks, regardless of whether they have Medicare but need pretty extensive needs, the program for all-inclusive care for the elderly, or PACE program. So there's a lot of different varieties of delivery systems, and fee-for-service is still available for some members.
So there's a question on, I think, slide 17, and we'll try to bring that up for you, about the per member per month amount on this slide. The question is, if the amounts shown in the bar graph are the amount spent per enrollee, not per enrollee who actually used that service. And that's right. So these are the amounts per enrollee who are per enrollee outside of capitation. It's not per enrollee who actually used that service. It's just per enrollee.
We have another question. Can you talk a bit or recommend any resources on how expected costs are determined each year? I think this means looking at MassHealth expenditures in total and how we measure it and how we look at it. We get our data on MassHealth spending directly from the MassHealth Budget Office. There are other resources, including there was a Blue Cross Blue Shield of Massachusetts Foundation report from November of last year that looked at per enrollee spending. That is a good way to kind of have more information on spending. And then there is also the Center for Health Health Information and Analysis just had their big annual report and the cost trends hearing. So there's more data available there as well. So there's a question about how can we find out whether our organization is qualified for the community partner program in conjunction with ACOs. So community partners have already been selected by MassHealth through a procurement process. There is a list of community partners who have been selected. You can find it on the MassHealth website. You can also find it in our publication, What to Know About ACOs. And that is how you can find out whether your organization is qualified for the community partner program. There's a question about how substance use disorder treatment services relate to day limits in MassHealth. I don't know the details to that, but I can say that federally, there is something called the Institute for Mental Disease Exclusion, where you usually can't have a person in long-term substance use disorder recovery and receive federal match for that. MassHealth, through its waiver, has some mechanisms for receiving match, but not full IMD waiver authority. I'm not sure from the treatment side what that looks like. I would recommend that you call MassHealth directly or refer to their publications about what services are available. There's a question about won't MassHealth costs go up as we reach out and serve people who have not traditionally received health care? As people who don't have health coverage receive more health services, yes, that does mean that the cost for those individuals will go up. But at the same time, if you think about a person and the course of their lifetime, receiving care earlier versus going to more expensive locuses of care like the emergency room because they haven't been receiving care is a way where costs are increased by not providing healthcare coverage. So this is obviously a very large body of work around that question. And I would refer you to look at what Massachusetts uncompensated care looked like in the form of what hospitals were paying for before Massachusetts expanded its coverage.
There's another question here about whether CPs can be in conjunction with several primary care ACOs. So yes, ACOs currently partner with all behavioral health community partners, and they partner, each ACO and MCO partners with at least 2 long-term services and supports CPs in their service areas. So, so the answer to that question is yes.
Okay, so I have a question. Is MassHealth considering reimbursing for other non-clinical SUD providers in support of SUD care, such as community health workers? I think when we're looking at recovery support navigation and also recovery coaches, those folks look a lot like a community health worker. There's a variety of different kinds of community health workers, requirements, expected role, that sort of thing. So I would love to have a longer conversation about this, knowing what the person who asked the question is considering. I will also say there is a new demonstration out of MassHealth in Worcester County and Middlesex County, connecting folks who are in parole or probation or leaving incarceration and connecting them to behavioral health providers. This is as a result of some of the data that the Massachusetts Department of Public Health and MassHealth looked at that found that deaths due to overdoses were 150 times more likely in the first few days and months after leaving incarceration. So that is a demonstration that is happening to help folks who are in that situation connect with behavioral health care. Okay. Are there any updates to what or if any SUD services delivered through telemedicine? I do not know the answer to that. I know that there has been some new telepsychiatry options. If I were in front of a computer with you right now, I would look up the provider transmittals on the MassHealth website. There is some information on that telemedicine and telepsychiatry option and what that might look like. I don't know if that would answer your question fully.
Great. So I think one more. Can you guide me to more information or a contact person for more information on reimbursement for community partners? I would refer you to the MassHealth, to MassHealth in general. They are, as you know, working on the community partner program. It's a very innovative new program that they're working through to figure out how to best outreach and connect people with the best care. If you're looking for kind of some background information before you reach out to MassHealth, I would refer you to what's called the DSRIP, D-S-R-I-P protocol, which is part of the 1115 approval from the federal government that goes in detail around how much funding is available for community partners through the 5 years of the demonstration. One thing to note about community partners is they are fully funded through DSRIP, which means that after 5 years, after 2022, funding is up in the air. So that's a big question for the Commonwealth. Great. There's another question here about the percentage of children that have medical complexity served by MassHealth. We don't have that answer offhand. We do know that about 46% of people with disabilities are covered by MassHealth. That's certainly probably a more narrow definition than medical complexity more broadly, and it is not specific to children. But hopefully that gives you some guidance on that question.
And if you refer to our slide deck from July of 2019, slide 10, there are about 42,000 children with disabilities as defined by MassHealth who are in MassHealth. And that children with disabilities does not match exactly with complex health needs, but that gives you an idea of the scope of the coverage. When asked what was the source you spelled, I think it was DSRIP, the DSRIP. Oh my goodness, you're gonna make me remember this acronym. It's a Delivery System Reform Incentive Payment Program. And it is $1.8 billion over the course of 5 years. We got that waiver approved in November of 2016. It goes through 2022. And the DSRIP funds are what help support the development of ACOs. ACOs are also paid, as you know, for the services they provide, but they also received some DSRIP funding for kind of setting up their business and starting to go. DSRIP funds also pay for community partners. They also pay for what's called statewide investments, which is a variety of programs, including help with workforce issues, help with improving access to care for members with disabilities, and addressing ED boarding for folks with behavioral health concerns.
Okay, so I think this wraps up our time for the webinar today. I want to give a huge thank you again to Rachel and Jesse for a lot of on their work feet answering these questions. If you have additional questions or other questions that weren't answered on the webinar today, we have provided our contact information on this last slide. You can also find the full MassHealth The Basics chart pack, which Rachel referenced earlier when answering the question about children with medical complexity. That's available on the Foundation website. And a link to a recording of today's webinar and the webinar slides will be emailed to you in the next few days. And the recording and the slides will also be posted on the Foundation's website. And again, if you would like staff from the Foundation to do an in-person presentation of MassHealth The Basics at your event or for your organization, please reach out to me, Catherine, at my contact info on the slide. We would also really appreciate your feedback on this webinar. We will be sending you an evaluation survey via email and really strongly encourage you to complete it. Your feedback will help us to improve our programs and to generate ideas for future topics for MMPI webinars, publications, and events. Thank you very much for your time, attention, and interest and questions on this important subject. Have a great day.